Naren, for the invitation and the very nice introduction. I'd probably like to add that my main practice is really general neurology and cognitive neurology. So I came late to normal pressure hydrocephalus for a few years now, but a much longer practice in cognitive neurology. But I think that's making it so that's the bit I can sort of contribute to the normal pressure hydrocephalus world. Now, I've not ever given a talk to a surgical audience, so I hope that this is sort of well attuned and will be helpful. Don't want to paternalize anybody. There will be bits that probably you sort of feel, why is he telling us that? But in a way, because it's such a short 15 minutes, I have basically chosen to present the neurological approach and then highlight a few things, and then we can basically talk about this afterwards if there are any questions. So I'll just share my screen. So I've got 3 parts to it: an introduction, something in the UK we call surgical sieve, which is an anatomical way of basically not forgetting potential differential diagnoses, and then perhaps at the end a couple of specific disorders that I want to highlight. Now, the relevance obviously is because normal pressure hydrocephalus differential diagnoses are most of them probably in the domain of neurology. Obviously, there are also neurosurgical ones, but many of them are in the domain of neurology. Now, the neurological approach, and I think it's not any different for the neurosurgeon, is the definition of the clinical syndrome, the phenotype. Now, there is probably a difference in that neurosurgeons can rely, due to the nature of their specialty, rely more on sort of macroscopic structural abnormalities. So, you know, you need to see something on the scan. But I'd like to highlight that whilst hydrocephalus is a structural problem, it certainly can be mimicked. Imaging changes often are equivocal, and they may even be coincidental. So the neurologist is very much used to diagnose by history and examination, or history alone. A diagnosis of migraine is purely on history, so we're happy and confident with that. Now, what is this clinical syndrome? The pathology that's likely to be underlying the patient's problem corresponds very much to the time course. So that's why neurologists spend a lot of time trying to find out when things started, how they started, how long they've been going on for, and have they deteriorated or improved, or are they fluctuating? And essentially, if something has been going on for months to years, it's a degenerative problem. As opposed to sudden, you wake up, have a right-sided weakness, likely to be a stroke. In between, so days to weeks normally are infectious, inflammatory, or malignant disorders. So with NPH, we're really within the domain of degenerative. So the symptoms and signs, though, they correspond to anatomy, and that will be important for the next slide. Now, neurologists work very much with diagnostic criteria. So these clinical syndromes, they have informed diagnostic criteria. And within those diagnostic criteria, there's usually a time course. So for the purposes of normal pressure hydrocephalus, it has to have been going on for at least 6 months, etc. There are core symptoms and signs. Now, investigations are always complementary. They are never the core symptom in neurological disease. They're usually exclusionary criteria as well. And then all this is stratified according to a probability. And this is informed usually by large clinical pathological studies, which is in a way a problem in normal pressure hydrocephalus, as there are no such large clinical pathological studies. Definitely requires always a tissue diagnosis. probable is based on symptoms and signs only. So again, symptoms and signs, not complementary investigations. They are supportive. So what about NPH? NPH is a clinical radiological syndrome as opposed to a clinical pathological syndrome. It's a triad, and there's usually hydrocephalus on brain imaging. Well, not usually, there has to be. Now, if we define the typical clinical syndrome of normal pressure hydrocephalus, the usual time course is one of insidious onset and gradual progression, so it will mimic neurodegenerative disease. The usual sequence is that the decline in mobility is first, and it is followed by a decline in bladder control and cognition. The gradient is that usually mobility remains worse than bladder and cognition. And the nature of symptoms usually is a shuffling to magnetic gait, bladder frequency, urgency, or incontinence. They have a dysexecutive syndrome from the cognitive viewpoint, but there are also other presentations, ataxia, they can be Parkinsonian, they can have bowel urgency, incontinence, and certainly they can have cortical cognitive features. I will come back to that later. Now, the issue with NPH is that from my perspective as someone dedicated to cognitive neurology, dementias, atypical dementias, movement disorders, the clinical presentation is really very heterogeneous. Having said so, part of the reason is that we often go from scan to patient, then from patient to scan. The other thing for the field is that there are no pathological hallmarks. Now, for the next few slides, I'm mentioning bladder control here only once. In isolation, it's not considered here, even though I acknowledge that it may be the patient's most prominent symptom, but I would not build my differential on the difficulties and with bladder control. The sort of relevant differential diagnoses that are cognitive and affecting mobility, they in fact overlap. However, still, as I said before, mobility in isolation, but in particular cognition in isolation, is actually much less likely to be normal pressure hydrocephalus. And that's helpful when you prioritize your diagnostic probabilities. So to the surgical sieve, this is an anatomical approach. And with regards to gait, obviously, you can have non-neurological reasons for that, musculoskeletal, so one would inquire and examine for bone, joints, and tendons. People may have osteoarthritis, they may have a connective tissue disorder. With regards to the neurological part of the locomotor system, if you start most distally, people can have problems with their mobility because of a muscle disease, for example, inflammatory myopathies, but they usually cause pain and a proximal weakness. Neuromuscular junction is the next, purely anatomically, myasthenia is the common disorder, but this usually affects the small muscles of the face, so not usually causing a problem with differential diagnosis. The nerve, for example, the commonest is the diabetic neuropathy. People usually have sensory symptoms, and on examination, low motor neuron signs. That's probably pretty frequent because diabetes is frequent. And it will sort of, which should be included in any formulation as to the likelihood of improvement, because it does certainly affect mobility. Root problems, I'm mentioning a surgical one here, lumbar canal stenosis. Again, people usually have sensory symptoms, including pain. Cord problems, again, surgical cord compression, but there are also sort of medical or neurological causes with a null MRI scan that normally should be picked up by finding a paresis, a spastic paresis in a sensory level. Now, the following ones, they can cause differential diagnosis difficulties, diagnostic difficulties, brainstem disorders, and I'm sort of talking about peripheral and central ones. They may present with a mobility disorder. So if you've got a vestibular problem, they may have other cranial nerve signs. Now, they should normally not have cognitive problems, so that may help. Midbrain is difficult. I'm mentioning here that one at the progressive supranuclear palsy. So if there's one thing to take away from this talk, it's certainly this condition. Pyramidal system, it is again difficult differential diagnosis if it's subcortical. For example, cerebrovascular disease. I will in fact not really talk more in detail about cerebrovascular disease, even though this is sort of the probably most important differential diagnosis. But I would even go as far as there probably must be an overlap between cerebrovascular disease and normal pressure hydrocephalus. But it's very variable in its presentation and very hard to pin down diagnostically, really. If it's a cortical pyramidal problem, then we talk about motor neuron disease. Usually you can pick that up on examination. People have a mixture of upper and lower motor neuron size, and they basically become weak. Again, extrapyramidal problems, they are difficult to differentiate. Any cause of Parkinsonism, and it can be vascular, or it can be any of those neurodegenerative problems, Parkinson's, Lewy body disease, which in a way is the same underlying pathology in a different distribution, and the same is true for multiple system atrophy. The underlying pathology is the same in all of those. By contrast, PSP and corticobasal degeneration, they are so-called tauopathies, so they are pathologically separate. But all of those are essentially the mainstay of a requirement for differential diagnosis. Now, cerebellar disease is really only difficult if it affects gait only. Normally, cerebellar disease also causes problems with the upper limbs, with the eyes, with speech, and they don't have bladder problems or cognitive problems typically, so shouldn't be too difficult to differentiate. Cortex, so cortical diseases, they are difficult if they affect the frontoparietal cortex, and one of those is corticobasal degeneration or atypical Parkinson's disease, basically. But again, usually people have other symptoms that may suggest why this is sort of not an NPH type disorder, but must be a cortical dementing disorder, neurodegenerative disease. Now, if you think in terms of cognition rather than gait, so you could sort of build your differential on, so if a cognitive problem is part of the presentation, essentially you divide this up into subcortical, cortical, and cortico-subcortical. So cortical subcortical typically presents as a so-called dysexecutive syndrome, and simply speaking, people are slow but accurate. So they try a task and they persevere with the task, and they take a long time, and their scores are normally reduced, but eventually they get there, and if they're given enough time, they actually usually, for example, remember. So compared to patients' Alzheimer's disease, for example, their scores on memory testing are not too bad. So usually they're complaining a lot, but the score is not too bad. And the Alzheimer's patient will not complain, but they are dreadful in the memory task, obviously in more advanced stages usually. So a typical subcortical disorder would be cerebrovascular disease, but again, PSP, what I mentioned before, the progressive supranuclear palsy. Cortical disorders, they cause typical sort of fancy neurological syndromes, amnesia, aphasia, agnosia, apraxia. I've highlighted apraxia because the corticobasal syndrome causes apraxia, and that may not only involve arms, it may also involve legs, and that's why people then may have difficulties with their gait for cortical disorder. I've also highlighted visuospatial, that's your Alzheimer's disease. So patients with Alzheimer's disease, they may not have amnesia, but they may present with a spatial disorder. And then typically they can't walk, but they usually also have difficulties with their upper limbs and in fact with their ability to see. So I highlighted Lewy body disease, LBD, and again PSP as cortical disorders. So you can see that PSP appears twice. Cortico-subcortical simply means that some of those disorders can have both, and again, Lewy body disease and PSP appear here. So it may not be as simple distinguishing those on the basis of this anatomical approach. Now, I mentioned that already. other anatomical areas, no cognitive disturbance is expected. So in fact, the absence of cognitive impairment at all should make you sort of think, oh, is this really normal pressure hydrocephalus? Now, a bit on memory, because they're so ubiquitous, everybody complains of their memory. Crucial to have a sort of working knowledge about the fact that people can have an either inefficient memory, so this is the subcortical pattern, or they can really truly be amnesic, a cortical problem. Their hippocampus is affected, with the difference being, again, the inefficient patient is slow but accurate. And you test them again after a delay, so 10 minutes later. And in fact, if you give them enough time and cues, so helped by cues, it's the recognition memory, it's not too bad. The cortical, the amnesic patient is usually quick, and they usually quickly learn, 7-item address. And then you ask them, after 10 minutes and it's gone. And then you try to cue them and it doesn't come back. So that's sort of on a quick way, a way to work out whether the memory problem is subcortical or cortical. Now I've picked out a couple of disorders and then I will have finished. So the first one I've picked out is the progressive supranuclear palsy. And the reason is that it mimics and causes differential diagnostic problems actually for several reasons. These are the diagnostic criteria, so you can see what a challenge that is and why probably a certain personality type is sort of interested in sort of being a diagnostician. Essentially, these people have problems with moving their eyes, they are unsteady, they are Parkinsonian, and they also have cognitive problems. Now, they may have any of those or a combination of them. And what these so to wake you up in a way, let's have a look at, oh no, here we are. So please have a look at this. A patient is asked to look up and down, but he moves right and left. So he can't really move his eyes at all downwards. And then someone takes his head and moves it. And then they're able to show that the eyes can move down using the vestibulo-ocular reflex. So this is your supra. This is this vertical supranuclear gaze palsy. So if you have this is very, very specific for progressive supranuclear palsy. The difficulty is that this often occurs late, or it may never occur, and you only have slowness. So you can still look down, but it's slower. Or if it's even less, you may only see the patient sort of having quick sort of movements right or left, called square wave jerks. Eyelid opening apraxia is that the patient is asked to close their eyes, open their eyes, and there may only be a delay in opening them. But if it's severe, they may have to use their hands to open it. Postural instability, this is something that will mimic normal pressure hydrocephalus a lot, because typically the people do fall, and that may be sort of the presenting feature. So this criterion is immediately met. And if it's sort of less level, so this is the level of certainty at 1, O1, P1, A1, this makes your diagnosis very certain. The lower you go, the less certain it is, but still to be considered. So here you only have a tendency to fall when you do the pull test, or here you do the pull test and they do a few too many steps. This is your Parkinson's, akinesia. Now this is a sub-disorder where people only have problems with gait freezing. A2 means that they are rigid in their axially mainly, and A3 means they look like Parkinson's disease, really. Now, this is the second bit. Again, I apologize for this very full slide. Here it's rated for you, the likelihood that you have PSP. Definitive needs neuropathological diagnosis, then there's probable and possible. As I already said, P1, P2, this was your problem with falling. NPH patients will fulfill that very quickly, or they may have Parkinsonian signs, a bit of a tremor, a little bit of rigidity, or bradykinesia. So you then need the eyes. Obviously, if the eyes come early, it's an easy diagnosis, but often the eyes come late. And that's why this diagnosis specifically is often mistaken for NPH. Obviously, it may coexist, but that's another issue. One other disease that I'd like to show you is the Lewy body disease. So this is a Parkinsonian disorder. Idiopathic Parkinson's disease is, say, motor only. Dementia Lewy bodies is dementia only, and Lewy body disease is in between. For our purposes, we use those diagnostic criteria. Again, you've got core features and you've got supportive features. Core features are either cognitive, so fluctuating cognition, or visual hallucinations. And then I would like to show you this one. Someone asleep, having a sleep study. So asleep whilst you does that. This is your REM sleep behavior disorder. Usually you need to inquire about that, but if this is positive, then your suspicion should be very high that potentially there is a neurodegenerative disease incoming. Parkinsonism is another core feature. So obviously you may have Parkinsonism and REM sleep behavior disorder, and that will make your diagnosis as I show you. So again, the biomarkers are only supportive. You've got probable and possible, but probable is 2 or more core features. So if you've got Parkinsonism, REM sleep behavior disorder, then you score probable. If you only have one core feature, namely Parkinsonism or REM sleep behavior disorder, and you have a biomarker, you can sort of consider that too. So I've sort of run through that, and my first conclusion, in a way, I didn't even mention it, but I would always recommend in the practice of NPH to have a neurologist as part of the team. Now, ideally, in an MDT clinic setting, so whilst neurologists are usually involved, there's often no cooperation. And I find that this is a problem. If people are seen separately in one clinic and then the other clinic, then the confidence is sort of lost in dealing with the patients. I repeat again, the neurological approach is the time course defining the pathology and symptoms and signs defining the anatomy. Use your surgical sieve, particularly for the mobility. And then I talked about individual disorders, in this case, Lewy body disease and PSP. So thank you very much. I'll stop sharing now.
Thank you. Thank you very much, Dr. Langheinrich. That's an excellent lecture. And it's really useful for us to have this lecture so we can go back and if we don't have neurologists, then it does help. But if we have neurologists as well, we know what to ask neurologists or what neurologists are talking about. But if I now go to Dr. Palandri, Dr. Giorgio Palandri, could you make your comments and questions? Your area is one of your area of specialization is adult hydrocephalus, and any insights also from Bologna. Thank you.
Thank you. Thank you very much, Tobias. I think this was really an excellent lecture, and I thank you very much for being here with us today. I think that I completely concur with you that this is not a one-man show. I mean, IMPH is truly a disease which needs to be handled by a multidisciplinary team. And I think that you as a neurologist are at the very heart of the team. So I think this was a truly important concept. I would like to ask you, how do you manage when, unfortunately, IMPH as not only a differential diagnosis, as also comorbidities, neurological comorbidities. Many of the diseases you mentioned are also comorbidity in IMPH. How do you manage this kind of patients? I mean, a patient with IMPH with Parkinson, maybe this should be a part of a tetrad in the future. How do you manage patients with IMPH and AD? What's your attitude in your daily practice?
Yeah, so thanks for asking that, because this is really very much the core finding sort of an exclusive IMPH patient is almost like finding a needle in a haystack. So they usually have always something else wrong with them. And that's why I was also saying that this collaboration is so important. So if I send a patient to the neurosurgeon who also has a diabetic neuropathy and who also has a lumbocanal stenosis and who also has diabetes, etc., they will never be shunted, understandably. Having said so, if the neurosurgeon understands that there is a medic involved who has understanding in these other diseases, one can usually find an approach which though is really very much a matter of discussing it with patient and relatives to make them understand that the probability of shunt response and how much and how long for, etc., is unfortunately uncertain. So in a way, all those patients should really end up in clinical trials to try and find out what's going to happen to them. Obviously, one learns as you go along, but it would be a better way organizing that formally. So we have sort of teamed up a bit in the UK, trying to look into setting up trials to answer also those other questions. And obviously, there is some information out there about a sort of complex NPH, basically. So the short answer back is MDT, very important for this.
Yeah, thank you very much for that. Okay, I would have another question for you. It regards specifically the role of diabetes in this patient, because you know, diabetes is a very common comorbidity. These are elderly patients. Polyneuropathy is very common in these diabetic patients, and diabetes is also thought to be maybe a common factor in IMPH. So how do you think we can manage this patient with diabetes? Because I mean, the surgical risk is slightly increased. They have confounding factors. For example, they could have difficulty problems with the gait because of the polyneuropathy. How do you evaluate this kind of patients, and how do you select this kind of patients specifically to send them to the surgeon?
Yeah, so there are various sort of aspects to it. One aspect is to try and gauge how severe the neuropathy is. Partly you can do that clinically by just tapping the reflexes and assessing, you know, for a sensory level. Not for sensory level, for how bad basically the neuropathy has spread. If I find it significant, then I tend to obtain EMG studies to confirm this. And I would certainly convey to the patient that I'm concerned that there is another additional cause for the difficulties with mobility. That but I would at the same time have to say that there is really no way of being certain at the end of the day how much benefit they will get. Sometimes one is surprised that people who have a severe neuropathy on an EMG seem to walk pretty well, and vice versa as well. The other aspect was probably more sort of triggered by my surgical colleagues. Obviously, you want a patient whose diabetes isn't too badly controlled in order to not be too representing too high an anesthetic and surgical complication risk, really.
Yeah, sure. Okay, do we have any question from the chat box? No, I don't think so yet. I would have, okay, we have one from Sushil. Is a CSF drainage the best way to settle the diagnosis, in your opinion, Tobias?
So the short answer is no. So I think CSF drainage has a role to play. And I think that was also sort of a little bit the intention that I had when I sort of said about a neurological approach, that investigations for neurologists are really subordinate. I mean, they need to fit in, and hopefully they are part of a complete picture and point in the right direction, but not that you would hang your hat only on the results of any stress tests, really. If it's helpful if it's going the right way, but you may even make contradictory decisions, really, meaning that the test may show one thing, but you're convinced about something else.
Thank you very much. We have another question from Uday. Well, I think maybe we are a little bit out of the field here, but what is the role of flow studies in NPH?
Yeah, so thanks that you just said a bit out of the field. From my understanding of flow studies is that it's certainly helpful for if there's a concern about any obstruction, but my understanding is that there isn't really good evidence to support sort of a positive criterion to say this is INPH as opposed to PSP, also just on the basis of flow studies.
Okay, I completely agree with you. Till now, they are not yet conclusive, even these findings, so we cannot really base our differential diagnosis only on the CSF flow studies here. I would have a final question to you, maybe a little bit intriguing. What's your relationship with the surgeons? I mean, how often is it that you contact he or she directly? Do you have the possibility, the chance to have a multidisciplinary team when and where the neurosurgeon is present too? You discuss cases together. What's your feeling? How could we improve this differential diagnosis, including the neurosurgeon in the team?
Yeah, I mean, all the time. I mean, on a not daily, but on a weekly basis, we meet. We may not meet face to face. So since COVID, obviously the remote meetings like this one, and in fact, to discuss radiology, for example, that's very good. The neuroradiologist will be at the other end as well. We may have performed videos of patients that we can review online, but certainly it's direct, and it's direct talking to them. So I frequently put patients on our NPH MDT list to be discussed, and that happens once a week on a Friday. And I would strongly encourage it. I mean, it was really an eye-opener for me to see how confidence and management changes just because you communicate directly. Yeah. I think that's very important. Thank you very much for your comment.
Thanks.
Professor Said, he does not want to talk about incontinence as a criteria. I think you said already something on it during your presentation, but maybe you should spend some minutes commenting on that.
Yeah.
Shailendra, is that your question? Your mic is mute.
Yeah, it is. I just wanted to know, has something changed since last time I kind of did some adult hydrocephalus?
Yeah. So no, I wasn't disputing that it's part of the triad or tetrad. What I was saying is if you sort of approach it differential diagnostically, then I don't have a sort of a surgical sieve that's based on the urinary disturbance.
Okay.
But that may be my ignorance. So, a specialized urologist may have means to sort of work from the basis of, I don't know, flow studies or whatever they do to sort of say that, it's more likely to be a CNS disorder. That was all I said. I did not dispute at all. In fact, I would always expect that people have, the more, and obviously that's sort of been proven anyway. A single symptom only of the triad is is sensitive, but it's not specific at all.
Thank you.
Professor Kenichi Nishiyama, NPH is a big thing in Japan. And I know that you are a pediatric neurosurgeon, but do you have any questions to Professor?
Yes. Okay. Yeah. Yeah. Actually, I sometimes doing the operation for the NPH. And thank you for the fantastic lecture. I learned a lot from you. And Japan has been actively promoting DISH and publishing various guidelines, as you know, and making it a hotspot for NPH research. At first, could you confirm the terminology first? I'm aware that lately, instead of saying INPH, we've been referring to it as Hakim syndrome when considering clinical conditions. Is that correct?
So I think, yes, there is sort of some controversy about the terminology. I'm used to using the shorthand of INPH to refer to a hydrocephalic syndrome, which is thought to be idiopathic. I'm sure it isn't. I mean, there is no idiopathic disease really out there. We just don't know about it. But idiopathic in the sense that there's no preceding disorder and that there's no obstruction there, and that it doesn't fit a congenital disorder. And in fact, this is entirely in keeping with the Japanese guidelines. So Hakim syndrome, I think people use it, but I'm not used to it. And it is though important. I think there is, in particular, the congenital ones and so INPH and what I often call LOVA. So I'm quite keen on trying to distinguish them, because I think they are, for me as a neurologist who works with symptoms and signs, they're different disorders. People are different, they're younger, they've got different heads. And as such, I try to distinguish them, even though there's certainly, I think, a great overlap in the literature about people calling anything just NPH because it's communicating.
Okay, I understand. Thank you. And as I'm a neurosurgeon, when I see the patient with INPH, I check the gait disturbance at first rather than the cognitive function. So in the process of differential diagnosis from the perspective of mobility impairments, it is necessary to consider abnormalities outside the central nervous system, including myopathy. I mean, for example, the visual impairment or the vestibular function or so.
Yes,
Please comment, please.
Yeah, definitely. So that's why I use the surgical sieve. So I think that's very important to look at all of those. So the surgical sieve is a little bit trying to be sort of non-judgmental. You just sort of say, look, they can't walk, and we'll start from the base and sort of look at everything, even though the history would already very quickly suggest that they don't have any of these other disorders. But I think the help of the surgical sieve is just to not forget to think about things. And that's why, in fact, mentioned the REM-sleep behavioral disorder. Sorry, you were talking about gait, I know, but REM-sleep behavioral disorder is an item that is almost never volunteered by patients, which I know because I sort of have a practice in cognitive neurology. But if you get this single item of information, it's extremely helpful to, for formulating your differential diagnosis. So again, this is the surgical sieve approach. You ask for it, even though there is nothing in the story as such that suggests that you have to ask for it.
Thank you. Yeah, it's good. Finally, please some comments about the CSF biomarkers, because in the AD, the p-tau or the A-beta 43. So some other biomarkers in NPH is we know that. So please, some comments about the biomarker.
Yeah, so I'm only used to using the ones that are sort of for us clinically available. That's amyloid tau and the neurofilament light. Now I have to say I've so far not been terribly surprised, perhaps because I've got a background in cognitive neurology. So there's usually a good correspondence between how people present cognitively and whether they're essentially their Alzheimer biomarkers are positive. And so far, I've not had anybody who had, for example, just a raised neurofilament light, normal Alzheimer markers, and ended up having PSP. But then I have to say that overall that this is rare, so I've just not come across it so far. I definitely think that it's very important to this field, and in the future this will be crucial and inform us about these differentials. Do we deal with comorbidity, and can we basically define it pre-mortem? There are biomarkers in Lewy body disease. They're not available for me clinically. So sorry, the DAT scan is, but not the what's it called? The CSF tests, like for the prion disease, RT quick. We don't have that.
Thanks.
Okay.
Thank you.
Thank you.
Yeah. Can I ask a question? Thank you very much, Professor Nishiyama. In terms of, when I saw patients with the NPH, it's obviously as a neurosurgeon, I wanted to be in the loop from the beginning to end. I did not want to just come as a technician. But obviously, it's very much a neurology disease that, it was great to have Dr. Langheinrich. And also I found it's also I'm dealing with patients with multiple morbidities. And whereas when you are doing a shunt in a pediatric patient, usually they are healthy patients and they recover well. Here, before you take the plane out to put the shunt, you have to make sure that the patient is actually at the best condition or optimized and nothing is missed, because last thing is that you take a patient to put a shunt when they have got high blood pressure, that diabetes, other medical problems, while they are waiting on the waiting list, you then find out they have got a brain tumor as well that has come up. So I know that nowadays everything is MDT. It has its positive, but it has negative. But do you think having a geriatrician or physician also on a MDT helps in, what would you say? Can I ask Tobias first and then to Giorgio? Thank you.
Yeah, certainly. I mean, having geriatricians involved, I think, is very important and helpful. As a neurologist, I'm not that used actually with sort of the geriatric side. Obviously, people with Alzheimer's disease are often elderly. Having said so, otherwise, neurology is actually a specialty that has many young patients, with MS, for example, epilepsy, etc. And in particular, the sort of the frailty is really an issue. Perhaps not so much in terms of the diagnosis, but more in terms of really, are we doing them any good, offering them invasive treatment, or are we actually too judgmental, basing our decision on just a high frailty score when in fact they may derive benefit? And for me, this is open. Yeah, so I would definitely say it would be good to have geriatricians involved.
Thanks. And Giorgio?
Actually, in Bologna, we have a geriatrician in our team, and I think that their role is fundamental, even for the diagnosis, even for the treatment, and even for the follow-up. Because here we didn't mention, because it was not in the talk by Tobias, the follow-up, but I think that speaking of IMPH patients, the multidisciplinary team is fundamental also in the follow-up of this kind of patients.
Thank you. This is last question. That's one for you for the chat box. So this is the last question. In terms of the differential diagnosis of failed shunt patients, in terms of your neurological sieve, as if it were, do you go through when you see a patient who's failed the shunt or has improved and stopped? Obviously, it might be the shunt problem, but is there any thoughts or insight for you to think that this might be a different problem, that the patient was shunted? Any thoughts on that? Because for me, the NPH is not a one operation thing. It's like any shunt patients. Once you do a shunt operation, you inherit them for life. And when they don't improve, you don't know whether shunt is not working just for the audience, that when you do a shunt in a child with a hydrocephalus, when the shunt doesn't work, the child is obviously symptomatic and acutely symptomatic, and the shunt is not working. Probably with the NPH is that you don't know whether it's a shunt unresponsive patient or shunt is not working, or there's another neurological condition. Any thoughts on this, Tobias?
Yes, absolutely. I mean, that's sort of a daily occurrence as well. Where again, I think MDT is very important, and as Giorgio said, the follow-up is crucial. That there are members of the team involved who are able to pick up on follow-up whether something else may have developed. Now, if a shunt has failed, it always seems to me sometimes to be sort of not 100% certain, as different practitioners seem to be doing different things. But certainly I would always leave that side to the surgeon, to be convinced that the shunt system works. But I would certainly contribute to sort of say, look, the patient has in fact PSP, or at least has developed it, and that's the reason why they don't respond. There are difficult situations when it's not 100% clear, but again, in this situation, it's even more important that there is sort of MDT practice going on, because otherwise the patient will be left to be dealt with by someone that may actually not have the clue to the diagnosis, if you know what I mean.
That's brilliant. So thank you so much, Dr. Langheinrich. Is an excellent lecture, which I will, if that's okay with you, I'll put it on our YouTube channel, which will be a great reference to everyone. And we usually nowadays translate it into Japanese, Chinese, in Russian, Arabic, and Spanish. So I will get them done. And since you are from Ulm, we'll do it in German as well.
That's right.
Thank you.
Thank you very much for giving me the opportunity. It was a pleasure, really, having been invited, and it was great to talk to you.